here, so I think people have joined. Shall we start?
Sir, you are on mute. Ajit sir, you are on mute.
Yes.
Ajit sir, you are on mute. Fatima, I think Ajit sir
Yeah,
voice is not coming and
yes,
even net connection is quite slow, no?
yes, sir. Yes, absolutely.
Agree. Thank you so much. Thank
No, I actually forgot it to connect to my home Wi-Fi. It was connected to the mobile Wi-Fi, and
you.
that's
Okay,
why the
sir.
range was not coming. Now it's all fine.
Yeah.
Super, sir. Super.
Now it's all fine. Okay, so sorry, guys. I think we have a good number right now. Shall we start, sir? If you permit, allow.
Yeah, please. 165. We all together put together. We are 165 now. Like
Yes,
166. Yeah.
yes. Yes, so we can start.
How many is supposed to be there, sir? Ajit sir?
So there will be supposed to be around
Oh, 200?
350 actually.
Oh.
Yes, 350. Yes. But I totally understand as this is a long course and we are starting on Monday. So it is understandable.
Agreed, sir. Agreed. I think in 5 minutes of time, at least 15, 20 more will join. It seems to be. Will we cross
Yeah. They
easily?
will be joining. They will be joining. They will be joining.
Yeah.
Yes, sir. So I think let's start. Let's
Sure,
start.
sir. Sure, sir.
Let them join. What do you say, sir?
Correct, sir. Please let us start
Because
170 already.
our speakers are also waiting, right?
Yeah. I can. Both our speakers are waiting.
Yes, sir. Yes, Fatima, please start.
Yes, sir, absolutely. Good evening, everyone. I hope you all are energized and excited because today marks the beginning of an inspiring, knowledge packed journey. Welcome to day one of the Oncology Pharmacy Conclave 2025, proudly organized by Climed Academy. It is truly fantastic to see such a vibrant community of students, clinicians, pharmacists, researchers, and healthcare professionals coming together with one shared purpose to elevate the standard of oncology care. Over the next 5 days, this virtual space transforms into a dynamic hub of learning, collaboration, and breakthrough ideas. We are here to explore cutting edge oncology therapeutics, real world clinical practices, and the growing impact of multidisciplinary teamwork in cancer care. So get ready because we are kicking off this conclave with the perfect blend of passion, science, and inspiration. I'm Fatima Juhaina, and I'm truly delighted to be your host for this exciting journey. Oncology is a field where every decision matters, every dose matters, and every conversation with a patient holds weight. This conclave aims to empower all of us with practical, clinical, and actionable insights that directly translate to better care, safer systems, and improved patient outcomes. And today, as we begin, we set the tone for an impactful, enriching learning experience. Before we commence with our scientific sessions, it is an honor to begin this conclave with an inaugural message from distinguished leaders in our field. I would first like to welcome Dr. Pramod Kumar Rajput, ex-Senior Vice President, Cadila Pharma, author, The Leaders with Ladders, Corporate Board Director, Pharma Business Leader, Academic Advisor, and Global Leadership Coach. Next, I would like to welcome Dr. Ajit Singh, founder and chief executive officer at Climed Research Solutions, Curio India, a young entrepreneur and scientist who has completed his PhD in cardiology from the eminent Manipal Academy of Higher Education, a leading organization in research and education in India. He was appointed as a research scientist for ICMR at the Department of Medicine, Kasturba Medical College, Manipal. He also serves as National Director for Research at World Youth Heart Federation and Principal Investigator for Manipal Heart Failure Registry. Sir, we are truly honored by your presence. The virtual stage is yours.
Thank you very much, Fatima. So I would like to invite first Sir to address the gathering, and then I'll be coming. So over to you, sir. First you.
Thank you, sir. Thank you so much. Very, very good evening to all the participants, all the speakers, Dr. Ajit Singh, sir, the organizer, Fatima, the clinicians, oncology pharmacists, researchers, and the dear participant. It is always a privilege to be a part of Climed Group. It is always a privilege. I repeat it. And again, also a privilege to join this Oncology Pharmacy Conclave 2025, a platform which is completely dedicated to strengthening the oncology education. As just now Fatima has revealed about it. We are going to speak about the advancing clinical excellence and empowering every professional involved in the cancer care. I am truly honored to be here for this important learning workshop of 5 days starting from today. Dear friends, you will agree it is so prudent that we are living in a time when oncology is progressing faster than ever before. New therapies, deeper scientific insights, and the stronger clinical systems are transforming how we diagnose, treat, and support the cancer patient. Yet, even with all this progress, the heart of the oncology remains the same: the skilled professionals, continuous learning, and the patient centered care. For India to advance in oncology, we must strengthen the four pillars. I just took the points from Fatima, and I'm sure we are going to strengthen about the same thing. One is the continuous skill development, which today we are going to have, and it's a continuous process, keeping the pace with evolving therapies. Second is multidisciplinary teamwork. Oncologist, pharmacist, and nutritionist working as one unit, including the nurses. Third is the research orientation, from case reports to the real world evidence, which is very, very important and prudent. And the last but not the least, patient centric care, ensuring the safety of the patient, empathy, and the dignity in every interaction. This 5 days conclave contributes to all the four pillars because I was reading the 5 days agenda. The great esteemed speakers, they are going to touch all the points. So they're going to make it so meaningful, the national initiative. Starting from the brilliant talk by Dr. Priyank Tripathi and Dr. Pravalika Vutukuru and many more learned speakers in the coming days. For all of us as attendees, I can say our knowledge will save lives, but our empathy will heal them. And to the special for the to gratitude to the experts and speakers, I can say your leadership is shaping the future of oncology practice in India, which is really required. And a word of note for Dr. Ajit Singh and the entire organizing team. Your effort, Dr. Ajit and the team, your effort in building this platform deserve appreciation and a great support from all. And that's the reason we all are here. As we begin the 5 days of the learning, I encourage each of us to engage fully, ask questions, share experience, and challenge the ideas and carry these insights back to your practice. We know that we are starting on Monday. It's all the busy day. But believe you me, the 5 days learning, it is very important because it's going to be a lifelong learning. Nobody can snatch that learning. And today, the amount of the speaker, the experts, they're coming, they are going to showcase the thing because they are the best of the best in their field. They're the subject matter experts. So let us learn together to create an oncology ecosystem where science is strong, systems are safe, and care is compassionate, which is evident. Let us commit to giving every patient not just more years, but better years. And that is the basic thing of the oncology. Thank you and wish a conclave a great success. Once again, Dr. Ajit sir, thank you, Dr. Pravalika madam, thank you so much, Dr. Priyank, Fatima, and everybody who is joining on this wonderful learning session. Thank you so much. Have a great conference, successful conference. Thank you.
Thank you, sir. Thank you very much for the appreciation and always being so supportive and being with us to address us, to guide us, and this is very important. The guidance is very important. Without guidance and support, we are clueless. We are pathless. So we need your support every time, and you are there always. Sometimes even you are so busy with your schedules. Still, on just one call, you are here with us. Thank you very much, sir, for being our chief guest for this and inaugurating this session, inaugurating this 5 days conclave. So, thank you very much, sir, for joining us. Thank you very much. Okay, guys. So, I'll just take 2 minutes, not more than 2 minutes. I will just say, as every time there is a story. There is a story behind coming up with these things. So, Dr. Pravalika has created the whole thing. I must appreciate her. Okay, so she has come up with the whole plan. She has come up with the whole idea. She has come up with the whole, syllabus, topics, and including speakers also, suggested speakers. So, because she is the expert of her field, okay, I don't have to tell. She is the expert of her field, and she has done her residency in oncology from JSS 2 years, and she has worked as a specialized oncology pharmacist in multiple hospitals, top-notch hospitals in India. She has been the head of oncology pharmacy, clinical pharmacy branches in the hospitals, and she has tackled multiple cases. Okay, and she has worked closely with the clinicians in this field. So I would like to appreciate Dr. Pravalika for this whole idea, and coming up with this wonderful conclave, right? So we were discussing in last month only, we were discussing like we should do something in this field. So she was like, let's do something, let's collaborate and collect and invite all the people who are great in this field. Okay, whether those are you can see the list of people who are joining us to share their experiences. There are the clinicians, there are the oncosurgeons, there are residents, there are head of departments, there are academicians, there are dietitians. I mean, where not, MD, medical oncology. There are people from yoga, there are people from sports nutritions, there are from surgical, I mean, people from surgical oncologist, and I mean, a lot of people are joining this course to deliver the best to you guys. Okay, so we are starting this today. It will be going up to 12th December. And every day evening you have to join us for next 5 days, right? Then only you will be getting the full-fledged knowledge, right? And as even sir has told, this is very important. And in India, it is one of the very emerging field, right? Very emerging field. So why we needed to do it something in the oncology pharmacy? Because see, pharmacy is one of the very integrated part of medicine, very integrated part of all the fields of all the domains of the medicine. So whether it is oncology, cardiology, or anything, but in oncology especially, the clinical pharmacists are needed, right? And they are much needed because they interfere with the things. They know the medicine better, they know how to calculate the dosage, they know which prescription must be there, which drug must be given, and which is the drug of emergency, and what kind of risks benefits analysis should be done before giving the drugs. Lot of things, and the counseling part to the patient, and telling about the strengths and weaknesses of the drug, side effects of the drugs. I mean, lot of things. There is a lot of, there is a big list of the tasks and responsibilities from the clinical pharmacy side in the oncology, right? So that's why it was much needed. It was much mandatory part for us to do something, in this field. And see, we are not just doing it for the first time. We are doing the same thing. I and Pravalika are doing the same thing. She's very close to me, my very, my elder sister, and a great, great, great teacher in this field. Okay, and we are doing this for I think 3 4 years, multiple years, since she has done her residency. We are doing multiple courses, we are doing webinars, master classes, and then finally she has come up with this ultimate plan. And I'll not take much time, but I must say, I must thank all the resource persons and speakers: Dr. Priyank Tripathi, Dr. Ritesh, Dr. Pravalika, herself, Dr. Sukesh, Dr. Kripa Bajaj, Dr. Lakshman Reddy, Dr. Srinivasa, Tejaswini, and Dr. Saranya, and Dr. Usha Rani, all for consenting to deliver their experiences, to share their experiences with us in this. a wonderful conclave. And other than that, I'm very proud, guys, very very proud to share that other than our interns, there were 300 registrations. The people who were interested in attending this, there were 300 plus people plus students who were very interested. And I'm telling you, most of the registrations came today. And since morning, my phone is ringing. Our company WhatsApp is completely ringing and full of the messages. Sir, can we register today? Can we register today? Can we register today? I told whoever wants to learn, please come and join us. So this is a huge success, and you can see that success in the in our Zoom meeting also. 212 right now I can see, and there are the people, as we are saying, this is Monday. Being on the Monday, the first day of the week, is still if 213 people are joining here, and almost 10, 15 people, 20 people are joining in the YouTube as well live. So I believe this cannot be more successful than this, and you guys, our audience, our students, the learners are making it more successful, guys. So thank you very much. And now I will go back to Fatima again. Thank you, sir, for joining. Thank you, Dr. Pravalika, for coming up with this such a wonderful plan. I'll go back to Fatima. Thank you, Fatima, for wonderful hosting as well.
Yes. Thank you.
Our permanent wonderful host from the hosting team. So guys, please go ahead and please start this wonderful program so people can learn, people can you know uh, you know get the experiences from these people. Yes. Thank you
Yes.
very much.
Thank you, sir. Thank you, sir, for the kind words and the wonderful inauguration. Day one is designed to build a strong foundation, focusing on the core responsibilities, safety practices, and evolving roles of oncology professionals. We have two powerful sessions lined up, delivered by experts who have shaped clinical pharmacy and oncology practice through their work, leadership, and research. We start.
There is a little correction. So first Dr. Pravalika will take and then Dr. Priyank Tripathi. Okay, Fatima?
Okay, okay, no problem, sir.
Yeah, thank you.
Yeah. Great. Okay. Then we will start with our first session for the evening, which is titled Standards for Chemotherapy Handling and Disposal. This topic lies at the core of safety, responsibility, and precision in oncology practice, and it is essential for every healthcare professional involved in preparing and handling chemotherapeutic agents. The speaker for this session is Dr. Pravalika Vatukuru, a PharmD professional who has completed her residency in oncology at JSS Mysuru and has served as the head of the Department of Clinical Pharmacology. She is well known for her expertise in oncology pharmacy, protocol development, and training healthcare teams in safe medication practices. With extensive experience across clinical practice, academic leadership, and oncology residency mentorship, she brings deep insight into safe chemotherapy standards that protect patients, professionals, and the environment. Please join me in welcoming Dr. Pravalika Vatukuru. Before we begin, I would like to remind everyone that we will have a Q&A session at the end, so please do keep your questions ready. Ma'am, the stage is yours.
Thank you, Fatima. Thank you for the wonderful introduction. And thank you, Pramod sir. Actually, the start with your words is very positive, very inspiring, and made the session more enthusiastic. Thank you so much. And we're happy that you have inaugurated the session because the first ever that an oncology pharmacy conclave is being conducted in India for the first time and for 5 days. And I'm happy that it has come on to the board after a long time of teaching so many classes. A place to learn all together at once. You may not learn it completely 100% what is there in oncology, but you can completely understand the panoramic view of what's going in oncology setup with clinical pharmacists and mainly pharmacists, and how pharmacists are playing a very important role in oncology care settings. Just not they have just entered clinical, still people are fighting for jobs for family in India. But this conclave brings you together, where you can see a healthcare team. We only listening a healthcare team, pharmacist is a part of it, but you haven't seen anywhere in life till today like how a healthcare team works. But in case of oncology settings, you can see that only when all the hands put together can make the treatments very effective and patient care better. That you can witness in this 5 days, where you will be seeing physicians, You will see bone marrow transplant physicians, hematologists, medical oncologists, clinical pharmacists, and you will see how they coordinate in a team, interdisciplinary, both the teams, like general physicians, how everybody coordinate in caring for a single patient. Just not one person's efforts brings you an outcome. It's not the right prescription, but the right preparation and perfect counseling. Just the counseling is not enough. You need supporting people, you need therapists, you need yoga therapists, quality of life is very important. Just not giving a right prescription, a patient is saved. So I'm very happy where we could bring out all the people here together to enlighten and highlight the roles and how are they actually practicing in cancer care. And I'm very happy to say your job does not lie or your salary does not depend on what degree you have, but it will reflect on all the skills that you have. You have a skill, you don't need a vacancy for a job. Go tell your skill, get your job, get your pay. I really support this, not just a family degree will give you a job. See, you have earned. Why I'm starting this is because I get so many questions. Ma'am, just clinical pharmacy itself is not, booming in India. How can you say doing specialization and working in oncology or whether cardiology, irrespective of any field that you want to get expertise, how will you get good salary? This is the first question I get rather than, ma'am, what should I learn in oncology? How should I go ahead in oncology is not the first question. How much salary will I get? How will I get? I will only tell you when you can. See, being a clinical pharmacist, what people does in exam, just write clinical symptoms, pathophysiology, but when it comes to treatment part, not antimicrobials, only loose tools is the adverse effect. You just want to pass the exam, but nobody will tell when to use, why to use zinc with people who are having diarrhea. Why do you go with, antibiotics? You can start with some sporlac medicine, right? Why is the question? When you know the answer why for the drugs in the department, whether it is gastroenterology, whether it is in nephrology, oncology, when you know why, when you can answer why for a drug, your job is ready with a physician. When you know how to counsel a patient regarding a drug and what to counsel, you need not be a Google dictionary with your brains. You should understand the process and know the resources from where you can get the information. And your expertise is not in extracting the information and tailoring the information with respect to the patient and giving it to the patient. When you this is you have to learn the process of getting expertise with the drugs in your own field and how to practice them in life. Okay? When you can do that, your jobs are ready. Then only you are a clinical pharmacist. If you don't know to do this, please don't join clinical pharmacy. I mean, don't enter a hospital setting. Okay, guys, it may be hurting, but I am true. You may start with zero. You don't need to have a good knowledge in oncology to become an oncology clinical pharmacist. But the attitude of learning will bring you success in this field. And your dedication matters here because you're dealing with patients' lives. So, guys, I wish you all a very happy learning. I'll try to don't check what is in PPT because I don't put points in PPT because you people divert your minds. If you don't ask questions, I will ask questions and please listen to my session. You will get an overall idea of what happens by a clinical pharmacist. Actually, if Priyank sir would have started with the session, you would have highlighted all the roles of a clinical pharmacist in oncology very nicely because he's a very senior most person in this field. And I'm very happy because I have learned from him a lot, the basics, the foundation. And thank you, sir, for this. And today I am starting this session and I'm very happy. I'll overall brief you what are the clinical roles, and sir will give you the insights and in-depth of that stuff. See, it's not just going with a physician. I'll show you the process, what happens in an oncology care setting before I start my session, so that you people see it's not just the journey of a cancer patient is not in single day that you come for diagnosis of a fever, telling some symptoms, take your medicine, go back home, and then finish, and you don't have any relationship with the doctor unless you will again repeatedly have symptoms, go to other doctor. It's a journey. Once you are diagnosed, till your life ends, you have a connection with the healthcare professionals in that field. Okay? Okay, guys, before I start, I don't take much time. And why are we here is just because why we are all here, guys. Anybody can answer? Because we all are healthcare professionals and mainly pharmacists who are on the front line of chemotherapy, compounding, and dispensing. Okay? We are here because our work involves potent agents that can both fight cancer and pose risks to the health of those who handle them. Before I start, may I know how many of you are pharmacists? Can you please type me in the chat box? Very good. And can I know like how many you are been to oncology care settings or you have not at all been? Yes, if you have been to oncology care settings. Okay, guys, no problem. If you have been, if you have not been, I will take you through this settings. Okay, I will explain you everything. Before we start, let me tell you what happens in an oncology care setting with the patient. So, guys, see here, before I start the session, this is nothing but a patient treatment pathway in oncology. What happens? Once the patient gets diagnosed, and the patient is referred to the oncologist or multidisciplinary team. And when the patient gets consulted with the oncologist or multidisciplinary team, what will happen? Assessment. Multidisciplinary team means a team of oncologists, surgical oncologists, radiation oncologists, medical oncologists. They assess the patient and they decide upon the appropriate treatment options in the tumor board. Tumor board contains all these people who will decide whether the patient needs surgery, radiation, or chemotherapy, or a treatment medically, which includes immunotherapy and all other treatments. And once his treatment is decided, the treatments are not given blindly to the patient. It is delivered to the patient with the discussion and a consent from the patient. So, oncologist and patient discussion concerning about the treatment options, benefits, potential side effects. So, the physician discusses, the oncologist discusses each and everything with the patient and patient's family. All the treatment options will be put in front of the family and the patient, and they have right to choose what the best treatment option you have. You can be asking me, ma'am, how will patients choose? Because it matters a lot. It's very expensive. There are government schemes. There are, benefitable schemes. They have, um, patient supporting schemes also, where patients get benefits of drugs. When they buy few drugs, they get few more for free, immunotherapy and all. So everything is not a generic medicine in cancer. So some are like clinical trials, people may get benefited if they are eligible. So all these options are discussed and consent is taken from the patient and patient family to receive a treatment or to give a treatment. Once the patient gives the consent, the patient gets admitted to the ward and chemotherapy prescription is given by the oncology physician, that is an oncologist. So before the patient receive the treatment, the oncology nurse assess the patient, all the basic assessment, height, weight, his blood pressure, all the initial assessment is taken by the nurse, and then patient education is provided by the nurse or the clinical pharmacist in the ward. Like what happens when they get administered, what are the extravasation precautions, hypersensitivity precautions, because they're very common in oncology wards. They will be educated on many other things of how they will be given treatments and all. An oncologist discusses, but even in the nurse, clinical pharmacist and nurse discusses these things in the ward. And then once the prescription is checked by a clinical pharmacist, mixing preparation of the drugs will be done after receiving the drugs from the pharmacy by a nursing team. Then cross-checking whether they have received everything properly or not, and then oncology nurse administers the medication to the patient. Then post chemotherapy, you have a supportive care medication prescribed to the patient that is explained everything in detail by a clinical pharmacist to the patient, and then follow up appointments and what investigations to be done by the patient are all explained by the patient. So after the patient goes back and comes, patient is followed up for side effects and all these things, and then next cycle when to come, what is the subsequent care plan based on the output or based on the outcome or based on the things how patient is reacting to the treatment. So the second cycle depends on how the patient is accepting the treatment. Then discharge management. So discharge and planning. And even after the completion of the treatment, patient will have follow-up where the patient will be coming subsequently to the hospital for his checkups and to see whether the cancer has cured or not, whether it has come back or not. Okay, this is what happens for a patient diagnosed in cancer care. Hope you all are clear. Yes or no, please type it. Guys, I'll not take much time, but I'll give you an overall idea. You understood what happens in a cancer care? Very good. So, before I go, why are we talking here? I told you we are handling very potent agents that will fight cancer, and they also cause risks to health of the people who handle them. So before we start, let me ask you, what are the hazardous drugs? You say all the cancer drugs are hazardous, but what are hazardous drugs? What are hazardous drugs, guys? Toxic drugs that harm women, just toxic drugs. What toxicity do they cause? Major side effects. Okay. See, the carcinogenic means that those drugs, when exposed, not only cure cancer, can also cause cancer if they are prolonged exposure. They harm the body. They're teratogenic. They cause reproductive toxicity. They cause genotoxicity, organ toxicity at low doses. They are irritant, highly potent. All these drugs, okay, are hazardous drugs. Okay. That is why we are talking about their handling and disposal, because they cause all the damage to humans who are handling them. Okay. So before we go, before we get into the practical steps, let's see the foundational guidelines that shape every aspect of our work as clinical pharmacist. Okay. So this is the disclaimer. I don't have any conflict of interest, and this talk is especially arranged to know our interests and build up careers based on our interest. Okay. We will understand the regulatory framework that governs the chemotherapy handling, identify key safety standards that directly impact daily pharmacy practice, apply practical tools for risk-free preparation, administration, and waste disposal, recognize pharmacists' role in promoting a culture of safety within the oncology settings. Okay, see here. See, these are the foundational guidelines that are used. In this USP 800 hazardous guidelines, this is the cornerstone for hazardous drug handling. They covers facility design, PPE, waste segregation, and training. If you are in a pharmacy that compounds chemo, so this is non-negotiable. You can use these guidelines. And okay, in OSHA guidelines, these are for for proper labeling, safety data sheets, and employee training on any hazardous they encounter. These guidelines you can use. Every chemo drug on your shelf must have a clear label and a safety data sheet readily available to know about the drugs. And NIOSH guidelines as for safe handling of hazardous drugs. These guidelines, they are on exposure limits, engineering controls. Okay, this recommends, closed system transfer devices. Wherever possible to reduce the inhalation risk, you can use these guidelines. Okay, and this EPA, these are, these are chemo waste and dictates how it must be stored, transported and disposed. You get trace contaminated materials that go into the hazardous waste stream, and we can't just throw them in regular trash. So this gives you all that. And state and local regulations, they're very much stringent, and they're like based into the institutional policy manual, and it's the final word of act that you should have to follow at your site where you are practicing. Okay. And from this, what you can take away is always you need to frame your institutional policy manual based on these guidelines and the standards that are required to practice in India. Okay. And why this compliance matters? It protects staffs, patients, and the environment. It reduces institutional liability and citation risk, ensures consistency across all oncology practice sites. Why typical institutional implementation? Because you have to develop policies to prevent people from risk of exposure to these drugs. Multidisciplinary safety committee oversight, regular audits, mock drills to verify whether these protocols are being adhered or not. Okay. Next one, risk overview. Why safe handling matters? Because the risks we are facing. Okay. First, let us see what are the different ways of exposure, okay, to these hazardous drugs. Maybe inhalational, dermal contact, accidental injection, and surface contamination. Guys, even a tiny droplet on a glove can be absorbed through the skin. Aerolized particles can linger in the air for minutes. Okay. And acute health effects like skin irritation, eye burns, nausea, headache, and hypersensitivity reactions can appear within minutes to hours of exposure to these drugs. These are often the first warning signs that something isn't right in the workflow. So you will have to audit and monitor what's going wrong in the process or what policy is not followed properly. Okay? And reproductive and long-term risks. Many chemo agents are teratogenic, mutagenic, or carcinogenic, and repeated low exposure is linked to fertility issues and increased cancer risk. The low dose myth is very dangerous. That is cumulative exposure to drugs. You know how people tell, slow poison is more dangerous, correct? So it's the similar way and the same thing. And improper disposal can contaminate water supplies, soil, and even affect patients and visitors who come in contact with the waste. Trace amounts in the sinks or trash can have downstream effects far beyond the pharmacy, means far beyond what the drugs the patients are getting exposed. And operational consequences, staff illness, increased turnover, in interruptions to patient care, and a single breach can shut down a compounding suit, you know, a single breach. So when something is means it can delay life-saving therapies. Means if suppose the person who is compounding is not well, there are three employees. If only two comes and a lot of patient load, the therapies get delayed. Okay? Because something is not proper that has caused ill health to the professional compounding the medication. Okay? Guys, before I start, do you know how many people have occupational issues or hazards due to chemo exposure? Can anyone? Can anyone, guys? How many people? Any numbers? Searching in Google? I'll tell you. 1 in 5 oncology nurses, they reported skin or eye contact with chemo in the past year. Okay? And heavy workloads double the risk. The patient load is more. The healthcare professionals who are working in oncology settings are very less. So the workload of oncology nurses have increased, but that have increased the experience exposure than those people who are having very little workloads. And there's some DNA damage. Because of that, they'll have mutation and chance of getting cancer. Roughly 8 million people, healthcare workers, are potentially exposed to hazardous drugs every year. And chemo spills become very common where standard practices are not followed. And chemo exposure is very high where the policies and procedures are not stringent in oncology care settings. How many of you have heard of nurses complaining hair fall who is practicing in oncology care settings? Yes, yes, yes. See, adverse effects are not just seen only by the people or patients who receive chemotherapy, but adverse effects are even experienced by people who are working or exposed or who provide or prepare chemotherapy. Okay, so chemotherapy does not mean only those anti-cancer drugs. It involves traditional chemotherapeutic drugs, targeted therapy, immunotherapy, hormonal therapy, or given systemically to the patient. But mainly the adverse effects are seen by this chemotherapeutic drugs because they act directly on the cell cycle. And all the cells who have cell turnover, right? See, skin cells, hair cells, blood cells, every day, they're undergoing cell cycle, but blood cells, they come from the precursor cells. So, and your cancer cells are also continuously dividing cells, and these body cells are also continuously dividing cells. That is the reason the common side effects of anti-cancer therapies: hair fall, skin toxicities, and GI toxicities. Liver and kidney toxicity, like organ toxicity, you will see very rare because you don't see your liver growing every day, right? It only grows when you are in need. Correct. So that is the reason you don't see those toxicities immediately. So you see them in the late effects, not immediately. But nausea, vomiting, GI toxicities, skin toxicities, color changes, nail changes, hair fall, all these you regularly see because they continuously grow. Say a small injury happens to your hand, a scar comes, it gets cured very fast. Why? Because they're continuously in cell cycle. And anti-cancer drugs, they act on the cells which are in cell cycle, and many are acting on different phases of cell cycle. So the characteristic is similar, but they're useless cells. These are useful cells. So you will see these common side effects with anti-cancer therapy. So we need to know Okay. So, as medication experts, we are the last line of defense before the drug reaches the patient and the environment. So, we are the last line of defense. So, to prevent ourselves, we need to know how to handle, prepare, and administer chemotherapy. Okay, today we'll be discussing about safe handling and disposal of the chemotherapy. The purpose of these policies in the hospital is to ensure the safe and effective use of chemotherapeutic agents in compliance with the like NABH standards usually, because you need accreditation in case and different accreditations. If you need to comply with those standards to provide optimal care and minimize potential harm to patients who are receiving chemotherapy and also people who are preparing chemotherapy. Okay, and the policies which are framed in the hospitals are involved in prescribing and are applicable to all the healthcare professionals who are involved in prescribing chemotherapy, preparing, administering and monitoring chemotherapeutic agents, including physicians, nurses, pharmacists, patients, and also support staff in hospitals or other healthcare settings. Okay? And chemotherapy is not prescribed by every physician. It is prescribed by the medical oncologists who are authorized to prescribe chemotherapy according to hospital institutional policies. And it is that almost all the infusions that are prepared and they're administered only in oncology units under the supervision by the staff assigned in the oncology ward. And these staff should be periodically trained in the safe handling preparation, administration, and disposal of these chemotherapeutic agents. Okay. So I have showed you the process of what happens there. Before anything, okay, let us understand. I told you the consent of chemotherapy is taken. So your institute will have to establish some standard guidelines for obtaining the informed consent for chemotherapy administration. It will protect the rights, promote shared decision making, and ensure compliance with the legal and ethical standards. Okay, and this will be done by the physician in charge. Okay. And these physicians have the ethical and legal responsibility to obtain the informed consent. And it has a specific points that should be covered in the informed consent form. Okay. And before that, we should understand the process of chemotherapy. In the process of chemotherapy, the first thing is you have, once the chemotherapy prescription is given, it has to be processed. So that is done by the nurse in charge. She indents the chemotherapy and process the order to the pharmacy. And oncology pharmacist or the clinical pharmacist or the doctor who is in charge will review the chemotherapy orders for the completeness. If there is incomplete prescription, you can talk to the doctor and you can follow up the ordering physician to ensure your prescription is complete. Okay. Once it is complete and the order is signed or approved by the uh, clinical pharmacy, so that is called as double signature that you will have to implement in your hospital, or double verification. And then the computer orders are processed in the computer. The chemotherapy orders are processed for confirmation. After the confirmation with the clinical pharmacist or the doctor on duty, what will happen? So once the pharmacist will receive the drugs from the pharmacy, all the employees who prepare, administer, and care for patients receiving chemotherapy or transport cytotoxic agents receive training initially and every 6 months. Why I am telling you this is because you are doing something. You are just a nurse in oncology setting, you cannot do this. So the nurses who are processing orders, all this, they are trained every 6 months. And people who are pregnant and who are trying to conceive or breastfeed, they are not allowed to get exposed to the cytotoxic agents. Why I'm telling you all this? Just processing chemotherapy, every nurse can process? No, nobody, everybody cannot process. So this processing of chemotherapy is done by those people whom to be excluded there. So once the drug comes from the pharmacy, the person who is receiving these types cytotoxic drugs, they will check for the external packaging, receipt of drugs, and also whether there's patient name, drugs, dose of vials received, whether the cold chain is maintained for the drugs based on storage recommendations of the drug. If in case something is inappropriate, the dosage is not correct, packaging is not correct, so they document the incident and then they return the drugs to the pharmacy. Okay, in case of a breakage or something, they follow the spill protocols, and damaged will be returned back to the pharmacy. In the process, the way it is designed in the policy, how to send back it to the pharmacy. They follow the institutional policy. And if they receive, if everything is fine, they'll store the drugs according to the storage recommendations of the manufacturer in the what till they deliver it to the patient. So receipt is done. After receipt, cytotoxic preparation. So they're always not done in the wards. They're always done in the chemotherapy preparation room that is located in the hospital. Okay. All the mixing, reconstitution, and preparing of chemotherapy, and principles of safe handling we'll be discussing now. Potential hazards of handling these hazardous drugs are educated to the nurse and explained to the people. And there is some hazardous drug list. The drug list is placed in the hospital wards. And what will happen, how many months this working staff are exposed to these hazardous drugs? What is the permission limit in case of radiation and all? They take care of this, the exposure limits are there. After that, they cannot work in the same ward for a longer time. But with chemotherapy, they start facing adverse effects also. They're shifted to wards. Continuously, they cannot be posted in one area. Okay. So, and where the preparation of this chemotherapy happens, it happens in a Class 2 Type B2 Biological Safety Cabinet. Why this happens here? And it is not horizontal airflow. It has an unidirectional airflow. And there's something called as HEPA filters. Why these HEPA filters are there? To prevent the particulate matter, to get filtered so that there is no air contamination. Okay, to prevent and the exhaust is in a way that these particles go outside the atmosphere in a manner that prevents recirculation into any work area. And it also has a continuous monitoring device to permit confirmation of adequate airflow and cabinet performance. So this is about the cabinet. And let's see the work practice controls. That PP, personal protective equipment, spill management, all this we will see. So, preparation of chemotherapy. Before something chemotherapy is prepared, that is there something called as preparation of the personnel. Okay? Everybody cannot prepare the drug. It should be ideally by a clinical pharmacist or nursing staff who is trained in safe handling and preparation of chemotherapeutic drugs, or a registered nurse who has undergone training in handling cytotoxic drugs and reconstitution. Okay. And another thing, all the people who are working in this area are prohibited from wearing artificial nails or nail applications. Like natural nails also should be trimmed, free of nail polish. Remove the watch, jewelry, other accessories, and roll the sleeves above the elbow. There's something called as bare below the elbow. So you should not wear anything below your elbow who are practicing in oncology wards. Okay, and hand hygiene. Hand hygiene is performed by all the personals before entry into the chemotherapy preparation room. Why they are doing hand hygiene? To minimize the microbial contamination of sterile products. Okay, and compounding personnel will have to wash hands and forearms for at least 1 minute with the soap under tap running water, and then will have to apply alcohol based hand sanitizer. And non-compounding personnel is the person who is supporting or helping out the compounding personnel with the vials. So they need not do any hand wash, but they can perform hand hygiene by applying alcohol based hand rub, which contains at least 70% alcohol, before wearing the chemotherapy gloves. Okay, in place of washing hands with soap and water. And why is this PPE? Personal protective equipment. I think how many of you have seen PPEs? I think most of you would have seen during COVID people wearing PPEs, right? So you have an idea what all a PPE contains. But there's some specifications in a people who wear PPE and handle these hazardous drugs. Okay? You know why people are wearing this PPE? To minimize or prevent one or more, things like, workers' exposure to hazardous drugs. Yes, the people who are working, exposure to hazardous drugs and particles in the clean room, and also the spread of chemotherapeutic drugs contamination outside the work environment. If they wear their own dress and go, it will spread, right? So scrubs are like low in cotton or cotton or polyester material. You have to wear scrubs. Lab coats must not be worn. Why you should not wear lab coats? Because they permit this permeation of hazardous drugs, and can hold spilled chemotherapeutic drugs against the skin. It can, it can penetrate to your skin. So it will increase your exposure. So you should not use lab coats and all. Footwear is like appropriate footwear, you have to wear. And shoe covers to minimize the spread of drug particulate contamination, hair covers, all this. And surgical masks are like minimum of N95 masks should be worn by the person who is preparing chemotherapy, and surgical masks is for non-compounding personnel. It will prevent the inhalation of these particles. And eye protection for splash protection, and chemotherapy gowns, and this chemotherapy gowns which you wear on your scrubs, the low linting impermeable disposable chemotherapy gowns, okay, long sleeves, tight fitting cuffs, you know and this will also decrease the risk of direct skin contact with the hazardous drugs. And chemotherapy gloves are worn by touching surfaces, and because that may be contaminated with chemotherapeutic drugs, so these should be tested for chemotherapy drugs. Gloves are powder free, long enough. Why you should not powder free? Just highlight it, okay? It's not the surgical gloves with powder. It's a sterile gloves with non-powdered, okay? Uh, and they have to cover your cuffs. Usually non-porous inner gloves, because if there is porosity, it can harm your skin. And sterile second gloves, that is also sterile, but it is not a nitrile gloves. It is sterile gloves. It should cover your, see here is in sterling powder-free nitrile examination gloves. It should be ASTM 6978. You can see the standards I have given you the guidelines. You can go and check, This both pairs of disposable chemotherapy gloves are worn by the personnel when handling these chemotherapeutic agents, and these should be changed every 30 minutes or immediately if there is a tear, puncture or contamination that is suspected. Okay. You can see here, this brand, Halyard brand, gives you chemo tested range. You can see the different types of purple nitrile gloves, which have been, some are like when you see your institutional settings, you can say what type of gloves you can use. Purple nitrile, see here 52 cytotoxic drugs and 25 dangerous chemicals. You can go to Halyard website and you can check the different types of glouses, purple nitrile glouses, like some comes in gray color also. You can check them, like see masks and 95 respiratory masks, all the PPE that is exactly required for chemotherapy preparation, you will find in this brand, and you can read here what are the different types of gloves, respiratory mask, what are all available, how it will prevent your exposure to this chemotherapeutic drugs. Okay, and you have some materials like syringes, needles, and alcohol swabs. Syringes are like different ml because there is having 1 ml. You know what different kind of syringes are present. Like 1 ml, 2.5 ml, 5 ml, 10 ml, 20 ml, 15 ml, and how to use them, when to use them, insulin syringes. Depending on the type of preparation and volume of the drug to be withdrawn, you should know which type of syringe you need to use and what kind of needle, and sterile alcohol swabs to disinfect the critical sites. Critical sites means suppose you're opening a vial, you're injecting a needle into that. That is a critical site. After preparation, because there is a like your puncture site, then you have to clean it. So for that, you have to use this alcohol swabs. Okay, so that it is sterile. And there's aseptic technique. So usually aseptic technique is means you're not there's some, I told you that biological safety cabinet operates with HEPA filtered vertical airflow. When preparing these chemotherapeutic drugs, you have to follow some procedures to ensure that there is clean airflow to prepare these drugs in a sterile environment. Okay, and manipulations must be performed at least 6 inches. See, guys, you may not understand these points when I'm explaining you or reading out. Please, you can go through the videos in the YouTube on how chemotherapeutic drugs are prepared. So that will give you a clear idea of what I'm trying to explain you here. How to adjust the chair height, and when not to use syringes. Syringes should not be overfilled or more than 75% full. And what type of syringes you will have to use, like lure lock syringes, all this stuff. So that when there are some oily preparations, a needle will not come out of the syringe and you can use them better. How many of you have you tried out using needles and syringes? Guys, have you ever used needles and syringes? Do let me know. We used them. Did you feel difficult in extracting with a 50 ml syringe or 20 ml syringe? It's easy or difficult? Difficult? Okay, one more question. When you want something, what you will do? Initially, you will take some air into the needle, push it into the vial, push the air into the empty space, and take it back. It comes very easy. Yes or no? Have you ever tried that? Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. Okay, lure lock is okay. You have tried that, Janani, have tried it. Okay, very good. Okay, you all tried. See, very nice. Suppose if your biosafety cabinet is not cleaned properly, you are taking the contaminated air into your syringe through the needle and you are injecting into the sterile vial. That means if there are any harmful agents in the air, you are injecting them to make your process easy to extract the drugs without any pain. Am I correct or not? Am I correct or not, guys? Come again. See, you are taking air into the empty syringe. And then you're taking the needle, injecting into the vial, pushing the air, and then you're taking back the drug very easily. It comes into the syringe. That is called as negative pressure technique. the drug comes easily into the syringe. But in that process, you are injecting the unclean air into the vial before you extract a drug. That means you are contaminating the vial. Yes or no? See, there's something, see, that is why you are using type 2B2 biosafety cabinets. And if the environment is free, that is why in biosafety operation, you have an UV light to make the environment sterile. But still, there is a chance on the way how you handle. So you should never use a negative pressure technique to extract the drugs. And another thing, if you can see, there is something called as closed system transfer devices where you need not use these techniques, but you have vial adapters and syringe adapters which you can use, which you can fix to the vials and easily extract without the hand pain. These are the recent development, and one of the healthcare have imported these instruments from outside India. But in outside India, there is a practice of this, and these CSTDs are now coming into practice. It's a little bit expensive, but it's a closed system transfer devices where you will not see any harm to the patient or environment or the staff who are preparing chemotherapy, where the very minimal exposure with the use of these CSTDs. Okay, I'll show you them, and if you want, you can watch the video in YouTube. Okay, Ajay Krishnan, you will better understand when you know what is the difference of using these normal needles and syringes, and how would you practice using closed system transfer devices. Okay, so you have to remove air bubbles because you have to, these all things can be prevented when you use closed system transfer devices. That air bubbles and all, if it comes, what will happen? The drug that you have to be extracted into the vial or something changes. The dose changes. Everything changes. So the techniques are very important when you handle those drugs. Okay. And waste disposal is very much important. A sharps container, puncture proof, and it should be very completely closed to dispense all the sharp objects, including the insulin syringes, the ampule tops when you break them, all these things. And non-sharp waste means which is not needles and all. It should be thrown into the respective bins outside, and you have a chemotherapy printed double colored yellow color cover where this is meant for throwing the chemotherapy waste. Whichever touches chemo, whether the vials, tops, the wrappers, everything that touches chemotherapy should have to be discarded in that. And then you will have to wipe with something like chlorhexidine gluconate solution, okay, prior to touching or removal from the BS. In case there is a spill, the chemotherapy spill kit should be in hand ready for cleaning the spills. Okay, sodium hypochlorite solution is used and absorbent in using the chemotherapy, in cleaning the chemotherapy spills. Okay. So what is your goal when a chemotherapy spill occurs? Is used to absorb and neutralize the chemical agent as quickly as possible. Okay. Usually in most of the institutions, they use 0.5% sodium hypochlorite. Okay. It's a hypochlorite is a very strong oxidizer that will break down many cytotoxic compounds. So they apply these to the spill area and leave it for a minute and then wipe it off. And secondly, they will clean it with an 70% isopropyl alcohol, something like that. So if what alcohol will do is it will dissolve any remaining drug residues and they will help to evaporate the bleach. so it will not corrode the surfaces. And they have to wipe that area after that when they clean it with a disinfectant. So, as a pharmacist, what is your role is to lead these risk assessments. You will have to take a lead and see what are the risks. You have to enforce the use of proper, not just PPE, proper personal protective equipments and closed system devices implementation in your hospitals, and ensure proper segregation to protect the environment, staff, and also exposure. And guys, you would have learned very thing little, but you understand you have lot of roles to play in making policies and procedures and changes, and you have to monitor periodically all this. So these are closed system transfer devices where these are used to incorporate into the syringe or needle. This is the vial adapter, you can syringe adapter, and all this are used instead of normal needles to prepare the chemotherapy. So guys, let me not take much time. See, you there will be some particle count and some tests that will be done to check what is the exposure in the biosafety cabinet. You have, they have some controls, airflow control, and whether HEPA filters are checked periodically. You have a protocol for all that. What about leftover drugs inside the vial? When I use 70% of the drugs, I have to discard the leftover. What is about safely discard? You have to discard it in a closed chemotherapy bin. How to neutral? You need not neutralize it because you're not taking of the drug. Drug is not falling anywhere, right? It is inside the vial. You have to discard the vial completely because that is all institutional policies. In a government care settings, if some amount of drug is used for the other patient, if another patient has the same drug, they can use the leftover drug for the other patient. But it's not same in private hospitals. So that is based on institutional protocols. What you will have to do with the leftover drug of a patient. Ajay Krishnan, that is the thing. Any other guys, any other doubts, please ask me, unmute your mics. You want to know something, you can ask me. Have you learned something out here? And do you know that when the urine samples of people who have been checked who are working in chemotherapy, some metabolites, chemometabolites were found in around 40 to 100% of health workers with cyclophosphamide. That is a very commonly that have been detected in most of the half of the urine samples. Okay.
Yeah, Dr. Pravalika, how much time do you need more?
I'm done, Dr. Ajit. They can ask me questions if they have.
Oh, okay. Dr. Priyank is waiting actually.
Yeah.
Okay, guys, please post your questions. And one more announcement in between. You all have to fill the feedback form every day at the end for attendance. Okay.
Harshada, I think Dr. Priyank sir will answer all these questions of internships and free courses and training programs. And sir is taking up in the hospitals few of them. And few of them, Dr. Ajit will answer you on of the courses in oncology. And Dr. Priyank sir, I'm very happy that you are here and we both are taking the session on day one. And as a person who have learned from you, I'm very happy to share this platform with you. Thank you, sir. Thank you for being here in the Oncology Pharmacy Conclave. Guys,
Hi. Good
questions?
afternoon, good evening, everyone. Uh, pleasure is mine to be around. Thank you, Dr. Ajit, Dr. Pravlika, for inviting me around. I was listening to the presentation. You have compiled indeed really nicely. Many congratulations for that. And it's an equal pleasure to share the stage with you. Dr. Ajit being a good old friend. Thank you so much for remembering and
Yes, hi Dr. Priyank,
inviting around.
welcome.
So it's
Thank you, nice
really
meeting
an
you.
honor
कैसे हैं आप
anyway.
सब ठीक हैं? All good?
All good, all good. All good.
Okay,
Still
so I think we are done with the questions. Shall we go ahead, Fatima?
Yes, sir, we can. We can definitely.
Please go ahead.
Yes. Thank you so much, Dr.
Pravalika, please stop sharing the. Yeah.
Thank you so much, Dr. Pravalika, for that wonderful session. Our next session for today is Empowering Oncology Practice, the Role of Clinical Pharmacist. This session truly captures the spirit of the conclave, highlighting the evolving and essential contribution of clinical pharmacists care. Our speaker for this session is Dr. Priyanka at CG Enterprises, Bangalore. Dr. Priyanka has extensive experience in clinical pharmacology, drug development, and clinical research, with a strong focus on optimizing pharmacotherapy to improve patient outcomes and introduce innovative treatment strategies. His work includes designing and overseeing clinical trials, conducting pharmacokinetic and dynamic evaluations, and ensuring strict adherence to regulatory and GCP standards. He collaborates closely with multidisciplinary teams to drive evidence based drug utilization, support therapeutic decision making, and integrate precision medicine approach into clinical protocols. Beyond his scientific expertise, Dr. Priyank is deeply committed to continuous learning, professional development, and sharing knowledge with the wider healthcare and pharmaceutical committee. It is my privilege to invite Dr. Priyank Tripathi to lead us through this insightful session. Sir, the virtual stage is yours.
Thank you so much, Dr. Fatima. Thanks a lot. Once again, formally, thank you so much, Dr. Ajit, for organizing this and having me around. As I said, it's indeed a pleasure to share whatever little we have gained over the years. Um, so, guys, my presentation today, doesn't include too much of oncology science. What I tried is to look at some basic stuff which we all at our own spaces have learned over the years and are able to understand our own space a little bit. I'm being fortunate to be in oncology for some time, and a lot of you are in your own respective specialties, learning the subject, learning science over there. So I've tried compiling those general aspects which are, to my understanding, to my belief, are important for all of us whenever we are sharing the stage with our fellow healthcare professionals, be it an oncologist, be it a nephrologist, be it any other clinician. So this next few minutes, or rather next half an hour or so, we'll look through those things. I'm sure a lot of it you would have read around in multiple places, multiple spaces, and might not sound something very new, right? But the only difference probably is our learnings over the years, as I said, right? What I would request, whenever you have any question, please post it in the chat. And if it is something that you believe requires, discussion, please feel free to note it down. Towards the end, we will definitely have a good discussion. I would encourage you all to please do that. uh, I was asked to talk about the role of clinical pharmacists. A lot of you would have attended a lot of workshops, conferences, which talks about role of clinical pharmacist in various specialties. I'll be focusing on oncology. That's been my forte. That's been my passion all across. So this is a little about myself. I'm associated with HCG Enterprises for past about 13 years now, trying to contribute, through my understanding of the subject in whatever best way I can. If somebody can confirm if if the screen is visible properly, is it okay?
Yes, sir.
Yes. Perfect. Uh, so this is what I do. I mean, apart from being, working as a clinical pharmacist, I also contribute a little bit towards research. I'm part of some of the initiatives taking care of the stem cell research, being part of stem cell research, committees and scientific sessions, scientific boards. also contributing a little bit to our clinical trials, conduct as well, being a member that side. And also, over the time, we were able to put on a dedicated, fellowship program, uh, which is Fellowship in Oncology Pharmacy. So I lead that initiative as well. So moving ahead, whatever I say, whatever I represent here, solely belongs to me. These are all my, my opinions about specific subject or specific aspect of oncology care. In no manner that it represents practices at HCG or views and opinions of HCG Enterprises. It's a mandatory disclaimer which I believe should be done. So what is the role of clinical pharmacist in oncology? If you ask me as a practicing clinical pharmacist, for me it's always patient centered evaluation. Everything and anything which adds to the patient's safety, which adds to the patient's comfort, which adds value to the treatment that you are offering to your patient, is something that a clinical pharmacist should do. We at our capacity, uh, when I say our capacity, we are the drug experts around in the entire healthcare ecosystem chain. When I say ecosystem chain, that essentially includes the clinician, the nurses around, the other specialties around. When I say clinicians, it's not just the oncologist, right? It's your physician, your nephrologist, your intensivist, every single healthcare professional who is around, who is contributing to the overall well-being of the patient. And in that effort, being a clinical pharmacist, at whatever capacity you are, whether you are into administration, whether you are into core clinical pharmacy, clinical routine practice, uh, you know anything and everything in and around drug use is something that I strongly believe belongs to us, right? uh, and a very important aspect I also believe, and this is my personal opinion, and this is what I also request my my peers, my colleagues, those students who collaborate with me or collaborate with us, is to remain academic, right? While we practice the profession, it's important. The nature of our profession is such that at a lot of times we end up finding deviations, we end up finding faults. Uh, I feel it is important that this particular aspect is practiced or demonstrated uh, as as an academic exercise more than fault finding exercise or fault finding assessment, right? uh, we have seen it transforming the practice, we have seen it transforming the way we think about something. Essentially, when I approach my fellow oncologist, a friend of mine who's an oncologist, and go and tell him that, buddy, you have done this, I mean, this is not right. Versus when I say that, this is something which we strongly believe can be optimized. And the reasons why I'm thinking the same. If I say that, the dose of a drug need to be changed, why do I feel so, or why am I recommending that, right? It's important that when we are talking to our fellow healthcare professionals, these behavioral aspects are also thought of, right? Trust me, that brings in a lot of I would say camaraderie between all the healthcare professionals. And it's important, it's important that we all work as a team, right? It's not just clinicians' job to treat the patient, to take right decisions for the patient. It's not just the nurse's job to ensure that whatever is advised for the patient or prescribed for the patient, uh, you know is just blindly followed or administered, right? So we act as a bridge over there. We act as a professional who help everybody understand that there is something more that can be done. There is more, if I have to keep it very simple, there is more flavor that can be added to the regimen that I'm preparing for my patient, right? It can be anywhere, not necessarily oncology, right? I'm sure a lot of you who have started practicing, or those who are interning, uh, if you are interning or practicing in domains other than oncology, say if you are somebody who is practicing in transplants, somebody who's practicing in critical care, somebody who's practicing in nephrology, cardiology for that sake, right? So this this aspect of the approach, I believe, adds a lot of value to our own knowledge set, as well as the communication and the trust that we build between the entire within the entire healthcare ecosystem, right? As I said, none of us can work in silos, be it anybody in today's era, when the information is so easily accessible. We all have to work together. We all have to work together for one cause, which is the patient care, which is the well-being of the patient. So when I say well-being of the patient, our presence should make difference. Our presence should be felt, and should be felt in a way that it makes a positive change in your patient's overall outcome of the disease, right? uh, I understand a lot of time we do not have a road ahead, when we go out of options, when we do not have any further treatment options for our patients. But point is, till that moment, have we tried enough? you know when we sit back and when we look within ourselves, do are we absolutely sure that we have done everything possible under this, under the planet earth, that can be done for this particular patient? Doesn't matter whether or not a guideline talks about it, doesn't matter whether a specific protocol talks about it. The way drug development is changing today, guys. You have one new strategy, one new drug every, at least every year, and in oncology even sooner, right? So if you ask me, again, this is my personal way of looking at it. uh, Nothing at this point is, no strategy or no treatment protocol or guideline at this point of time is permanent. Everything is moving, everything is very, very dynamic. Point is, how dynamic are we in adjusting with it? For that, how dynamic are we in understanding not just the drug but also the disease? It's important, it's very, very important that we understand the disease while we understand the drug. If we do not understand the disease, you know trust me, anybody and everybody today can open any of the GPTs and scroll through a proper drug information. Our presence matters when we add value to that, right? And that comes when we understand our domain better, that comes when we understand the disease better, that comes when we understand how, why, when, right? It's important that we ask questions. So what happens, typically in an oncology clinic? So we, not just me, but I would rather say we. So we are a team of about 12 clinical pharmacists at our Bangalore center, while we are about 38 of us across HCG network. So something in common that everybody does, ensuring that we review and optimize the therapy and therapeutic plans. So it can be patient-specific dosing based on whatever method that is applicable to that patient. If you are dealing with an adult patient, we do the dosing either based on the body surface area or body weight. If you are dealing with a pediatric patient, you might be opting body weight, body surface area, and possibly some other appropriate formulas, for calculation of the drug dosage. Another very important aspect, and I'm sure Dr. Prablika was also touching upon it, it's about understanding the physicochemical stability of your drug product. Now, the kind of drug products that we use in practice, especially in oncology practice today, a lot of these products have very limited physicochemical stability, right? So it's important that being a drug expert, we understand that physicochemical stability aspect of the formulation or this chemical that we're using as a drug today, right? So people ask a lot of time, after securing PharmD, do I really have to sit and do reconstitution? I'm personally, a propagator of that for one and only one reason. I don't think anybody other than a pharmacist, whether I'm a PharmD, whether I'm an M Pharm, whether I'm a B Pharm, anybody other than a pharmacist understand a drug both from this being a chemical and this being a treatment, right? When I say so, and when I myself sit for drug preparation, I keep that aspect in mind, right? So when I do that, if I'm, say for example, I'm reconstituting or observing or supervising a drug preparation, and I see that a drug X should be final formulation should be say should be a clear liquid, uh, but I'm seeing that there is some difference of color, possibly a pinkish color. Now, whether this pinkish color is a contamination, should I go ahead and administer the drug? This pinkish color represents, uh, you know, degradation of the drug product, or this pinkish color is normal. It is nothing but just the drug, right? So for somebody to sit and understand that, I think there's nobody better other than a trained, CP who can effectively do it well. So I personally am a propagator of CPs being, involved in drug, preparation practices. Might not do it themselves, but be part of the entire program. Ensuring that the when we talk about oncology, of course, we do talk about protocols. And now I think somebody would definitely say that, a few minutes back I was talking, to go beyond protocols or think beyond that and all those things. But having said that, the protocols which are laid down after thorough research and clinical trials and experiences. That gives us a base to, where to start, what to do, and of course, that gives us an idea about, what is the right type of regimen for a patient. But when we talk about oncology, what's important is personalization. You cannot, at this point of time, today, in the era of personalized medicine, we cannot generalize a therapy for a specific patient, and we have seen enough number of examples of it today. Every week, couple of times in a week, we see about 50 odd patients who are, otherwise, possibly, if they were treated normally, possibly wouldn't have responded as well as, we were able to bring that change in their lives after thoroughly researching about their genetic makeup, looking at, their genomic signatures that the tumor is, or the cancer is showing, and deciding the treatment based on that, right? If I would have chosen to go the guideline way, possibly I would have given a couple of chemotherapy or two, three chemotherapy drugs with possibly one or two biological therapies. But I know that the patient might not do well if I do that, right? And to understand that, it's important that I understand what are the arsenals, or what are the, what I have in hand. Can I, what else that I can do, right? um while we talk about oncology, we talk about cancer management. So it's very, very important that we also look at the comorbidities, right? We also look at, the infection, which is unfortunately one of the biggest reason for mortality and morbidity in oncology, right? We essentially should look at, all possible comorbidities that can, those pre-exist, or also those are induced by the treatment, or possibly by the disease itself, right? It's important that we understand that aspect of impact of disease on an individual's overall health. So if you have a patient who possibly is on drug which can cause hyperglycemia, you should also understand and do your preparation to ensure that you know what would be your next step, right? So to give you a very small example, All right. There are these drugs called CDK4 bar 6 inhibitors, right? Abemaciclib, etc., etc. Those colleagues of mine who are interning in oncology or who are practicing oncology must be knowing it. So these CDK4 6 inhibitors or this PIK3 inhibitors specifically, if I talk about abemaciclib, I'm sorry, the PIK3 inhibitors. Right. What happens with these drugs is these drugs are known to cause hyperglycemia. So you have to prepare yourself. You have to prepare your patient that at some point of time you may face this discomfort. And as part of the treating team, see, when in good oncology centers, I'm sure a lot of not just a lot, in fact everybody today, everybody has essentially has a CP in their team, right? So if you are part of the team, it's important that we think we think in advance about how will I manage complication A, B, C, D, E, right? And it's also important if to take that next step in understanding, is there anything else that can happen? Might not be documented. Remember, might not be documented, but uh, you have to understand the drug's kinetics. You have to ensure that you put effort in understanding the drug dynamics. You have to put effort in understanding the molecular way this drug acts. You have to put effort in understanding how possibly the disease or the cancer may respond to it. You today we have a lot of genomic markers or the pharmacogenomic markers that can help us in doing that. You have to think how possibly the disease may acquire resistance against the treatment. We all understand that one of the reasons that the therapy fails in cancer or we lose battle in cancer is because the disease or the cancer itself drives a way to become resistant to the disease, resistant to the drugs. I'm sorry. As a dedicated oncology clinical pharmacist, it is important for us to understand those mechanisms. It is important for us to understand, how a cell functions. It is important for us to understand, if I have to, have to be very technical, it is important for us to understand the upstream and the downstream signaling pathways which are responsible for development of a cell or death of a cell, right? Until and unless we don't understand that, it's extremely difficult for us to to contribute at a point when the treatment starts failing, right? When you start learning about those aspects, tomorrow when your patient possibly fails the treatment, you know what possible arsenal you have in hand. Can you say, for example, if your patient is on immunotherapy, you found that certain markers are not in line with prescribing immunotherapy, but can you do something to make this tumor more responsive to immunotherapy? Answer today is yes. And this answer came from the fact, from the understanding of how the disease expresses itself, what happens inside the cell, what happens inside the microenvironment of a cancer cell or the tissue. If we understand that, we know how to possibly, at least till some point of time, to change that microenvironment and let it work in our favor, let it work in favor of the drug, right? The classical protocols may not define it, but as a expert, it is important that we understand or we try to understand these aspects, because at some point of time we'll have to go beyond protocols. At some point of time we may exhaust options. At this point of time, when you're exhausting options, do you have anything in hand to add life to years of this patient? Is the challenge, which will be in front of you every time when you are part of a multidisciplinary team treating a cancer patient. Well, in line with it, it is important that we not only understand the classical drug-drug interactions, drug-food interactions, etc., etc., but we also understand drug-disease interaction. I've given a small example over there. This is from the real life what we did. This is not picked up a pick from the from the internet, but instead this is something that the team did over here for one of the patients, and we could alter the therapy in favor of the patient over here. A very simple thing. We are talking of couple of antibiotics. Changing one to the other have made all the difference, right? Now, what is important is evidence-based adjustments of the dose and the drug. It's not just the dose, but also the drug. Please read it as drug and dose adjustments, which are made, with with proper evidence. When I say proper evidence, not just the FDA labels or EMA labels or the literature recommended changes, but also based on your understanding of the disease and the body dynamics, right? For example, you have a patient with a single kidney, right, with renal cell carcinoma. Question which will come to you is, how much should I dose an antibiotic to my patient? Should I dose it full? Should I dose it 60%? Should I dose it 40%? Right? I have a patient with, say, for example, with certain liver abnormality. What should I do next? Which antibiotic should I choose? Which chemotherapy? If I'm choosing protocol A, is it all right to give full dose? If not, what should I do? Should I do any additional test? Is it required to do any pharmacogenomic marker? If not, what other markers should I do? What should I what should I look for? Right. So is for cardiac functioning. So is for the comorbidity, and then of course the concomitant medications, which I'm sure we all get trained through and through. One very important aspect, and is the reason that I have marked it in bold and italics, is pharmacogenomics, guys. If you are somebody who is looking forward to make to influence somebody's life and treatment decisions. Now, I'm not talking about heroics here. I'm talking about genuine effort in in deciding treatment of a patient. Pharmacogenomics or personalized medicine, precision medicine is the only way ahead, right? Today, when we are looking at treatment options, especially if I'll stick to oncology. Today, when we are looking at treatment options, we are looking at bispecific, trispecific, antibody drug conjugates, where there is one antibody carrier which is taking up a drug, right? And these drugs, now this antibody has two or three, we call it payload, two or three payloads, where it is carrying one chemotherapy metabolite, second chemotherapy metabolite, third chemotherapy metabolite, and targeting three different triggers which are causing cancers at one go, right? If I have to implement such strategies, or if I have to use such drugs for my patient, I should first understand where, why, and how does everything functions. If I'm saying that I'll be using a anti-CD19 therapy, I first have to understand what anti-CD19 is. What are these CD signals or molecules or genomic markers are, and do they affect everything? Can I use a drug possibly which is a drug used in hematological cancer? Can this drug be used in in somebody who is suffering with a solid organ cancer, right? uh, a lot of times answer is yes. I'll not say every time. Of course, you have to make a very informed and evidence based decisions, because you are playing with somebody's life. Your one decision, trust me, when you work in multidisciplinary team kind of a setup, everything whatever you say and anything whatever you say is treated very very seriously. As a clinical pharmacist or a pharmacologist at whatever designation domain that you're working with or would be working, people, when I say people, I mean healthcare professionals. And trust me, I'm talking from a, a fresh graduate DM healthcare professional to a very very experienced oncologist, somebody who's really big in oncology. They would be looking at you, when you are giving your opinion that yes, drug X can be given. They really think about it very seriously. They really consider it seriously, right? So this is the kind of responsibility that we all carry on our shoulders when we are when we are talking about a treatment, when we are talking about a drug, when we are talking about a treatment strategy for our respective patients. Well, oh, I'm sorry, some glitch, very sorry about it. Okay. Then comes those very routine works, which are, I'm sure a lot of you and all of you would have heard about it, read about it. The medication stewardships. It's important. The reason I mentioned here, every single aspect of what is mentioned here is very very important. It's important that we look at antimicrobial use as part of the antimicrobial stewardship program, and the team very seriously. As I said in starting of the presentation, the antibiotics, the misuse of antibiotics and the infections, unfortunately, are biggest one of the largest reason for comorbidities and mortality, in cancer patients. Steroids. We use a lot of steroids in cancer therapy. We try to use steroid sparing therapy or steroid sparing protocols, but steroids are very very widely used in cancer therapy. Be it part of the anti-emetic protocols, be it part of the treatment regimens in case of lot of hematological malignancies. Steroids are very integral part of cancer treatment today, guys. Even when somebody is receiving radiotherapy, right, to reduce edema, steroids are being utilized. Again, as I said, I mean, with your constant effort and with your with your understanding of the disease, I'm sure a lot of you would have come across protocols which are steroid sparing, but that that understanding is very very limited today. So it's important that we do a very close monitoring of steroid use in our respective hospitals, and that responsibility lies on us, right? Next important aspect are opioids, right? Opioids, again, as I said, I mean, as we understand, are very widely used in cancer pain management, are part of surgeries, right? Whenever we are doing anesthesia inductions, a lot of time opioids are used. Whenever we want to achieve optimal pain control, as I said, especially in oncology, opioids are indispensable at some point of time. But it's important that we monitor these drugs. It's important that because of the regulatory uh, uh, risk to the institution, if somebody misuses your institution and you are, quite viable, quite, held responsible for whatever happens about the misuse. If your institution is the one and if you are the one who is managing it, a lot of time that responsibility falls on us. And of course, anticoagulants. Now, the reason, this anticoagulant stewardship you might not see at many places, but this is something that that is something I personally feel requires a lot of attention. The reason being, uh, cancer itself, the kind of metabolic changes that cancer causes, it itself is one of the risk factors for deranged coagulation. When we talk about deranged coagulopathy or coagulation, thrombus and thrombosis related effects are very very high in patients who are diagnosed with cancer. Essentially, if you look at the guidelines, the use of anticoagulants is being warranted in patients who are diagnosed with cancer. So it's equally important that we choose the right kind of anticoagulants. It's anticoagulant. I'm sorry. It's important that we choose an anticoagulant which does not interact with my treatment protocol, treatment regimen. When I say it does not interact, it's not just the direct interaction. It's not just that anticoagulant A is metabolized by CYP3 enzyme and my chemotherapy is metabolized by CYP3 enzyme, so there is an interaction. Of course, it is, but you also will have to look at the uh, you know the possible toxicities that your patient may undergo when they are on a specific chemotherapy protocol. Say a patient can have liver toxicity when they are on a specific chemotherapy protocol, and the anticoagulant that you are using also has the same, possibly, right? Or its effect may get augmented in case of liver injury. So you have to be very very cautious and ensure that your treating team is aware of the fact that uh, a specific abnormality in the liver can cause a deranged clotting parameters that can affect the overall impact or effect of your coagulants or anticoagulant. I'm sorry, effect of the anticoagulant. So it's important that we not just read through what is written, but we also understand what is written in between the lines. It's very very important for when you are there as a as a drug expert. Also, when we talk about stewardship, when we talk about all these aspects, there are a lot of avenues to look at new treatment regimes. There are a lot of avenues to look at how we can repurpose certain drugs, etc etc. Another very very important role that we all play, I'm sure you all are aware of this, but it's very very indispensable, I would say, when somebody is practicing oncology, especially a clinical pharmacist or a pharmacologist. When you are in oncology, it's extremely important that we pay utmost attention to medication safety, right? Uh, because of the fact that the drugs that we use, not just the chemotherapy, but the biological therapy, the other targeted therapies that we use, carry a very, very significant risk of harm if they are misutilized even a fraction here and there, right? So proper protocols and ideas to identify medication error, to rectify medication error, to report medication error, to do proper root cause analysis, and ensure that the respective corrective and preventive strategies are implemented in the hospital are your responsibility. From the regulatory point of view, NABH in the recent sixth edition mandates having a medication safety officer, which essentially in large hospitals and majority of the hospitals are senior clinical pharmacists, right? So this is the kind of responsibility that you carry. And as I said, I mean, the kind of risk that we have with drugs those are used for cancer, uh, it's it's crazy, to be least, right? To give you a small example, we all would have heard of methotrexate, right? Methotrexate at various dosages is used in treatment of lot of cancers. We use methotrexate to treat blood and blood related cancers. We use methotrexate to treat lot of solid organ cancers, right? Now, this drug, when we use in high dosages, uh, we have to follow a specific way when we give it to the patient. The patient's pH should be neutral or basic. You know, we have to ensure that the other vital organ functioning is appropriate at the baseline when we start it. Patient doesn't have any baseline infection. Liver is functioning appropriately. There is no baseline mucositis or risk of mucositis. Cardiac health is all right. Kidney health is all right, and patient is appropriately hydrated. Very, very important. These are very small things. Checking the pH, somebody misses, your patient is at very high risk of harm, in fact death. We have seen it, and we have read it, we have spoken about it multiple times, right? Very simple thing, hydration. If a patient is not hydrated appropriately, in a lot of cancer drugs, it's not just methotrexate, not hydrated appropriately, and which is essentially part of your entire treatment protocol, right? Treatment protocol does not necessarily includes your drug ABC and your pre-medication XYZ. It includes preparing your patient before and ensuring a patient after the administration of the drug is is safe. We have implemented enough strategies to ensure that the patient is safe pre and post the treatment cycle has been administered. As we all understand, the treatment of cancer is not just one sitting treatment, right? It goes on for years and years and years. Sometimes it's lifelong, right? Today, guys, with the advent of technology, with the advent of the kind of drugs that we have, and I know I will not be surprised. Even a lot of cancers today are such that those can be managed like we manage, hypertension, we manage diabetes, we manage other lifestyle disorders, right? So it's important that we not just look at the therapy, but we also prepare our patient before, during, and after the therapy as well, right? So every small little detail matters a lot, right? Coming on to the other medication safety aspect, I'm sure the bullet number 2 is something which is very well known to all of you: adverse drug reaction analysis and reporting. It's especially important in oncology because we are seeing a lot of new drugs. We use a lot of new drugs, so it is important that we understand the effect of these drugs, especially the adverse effect of these drugs in our population, right? Please remember, drugs are approved in clinical trials where we have very limited exposure to very limited type of population. The way an African individual responds to a way a Caucasian individual responds to a way a Asian individual responds to a way a South Asian or somebody who is in Indian subcontinent response is very, very different. We have different genetic makeup. The difference might not be very huge, but whatever little it is, it has a very, very high impact on the way we respond to medications, on the way we respond to food, right? So it's very important that we look at every single adverse event seriously, whether whichever grade, it doesn't matter. It's important that we report. It's important that we create that environment in the hospital of reporting adverse events. You have to teach your nurse, you have to teach your junior doctors, to encourage them to report, and you have to be available for, to hear them out when a nurse of yours calls you, that a patient has, is suffering with ABC. You have to be available either over a call or in person, preferably, to go and see that patient to understand what's exactly happening. It's not just about reviewing the chart and giving the dictum. It's about being there, understanding what's happening to an individual, right? And keeping a database or a record of it, and to continuously every month or every quarter, do an analysis of what's happening in your patient population, your subset of patients. It's also important, if you're somebody, if you have the bandwidth, or if your institution has the functionality or the machines to do genomics and such advanced diagnostic workup. It's important, very very important, to look at those. You can pick up those, and academically we can pick those patients, do genomic analysis on those patients, and see if there is any of these adverse events have any, have such pharmacogenomic links, right? Might not be documented, trust me, might not be documented, but when you start looking at the common commonalities, I would rather say the commonalities in the pharmacogenomic markers amongst the patient, you'll be surprised to see that possibly you might end up finding one, right? And at the end of the day, who's benefiting? Your patient is benefiting. If I say that a lot of my patients have, say, ABCB1 abnormality, or ABCB1 is expressed, or there is a mutation in ABCB1, I know that this patient is at a very high risk of developing resistance, because ABCB1 is one of the transporter gene which throws the medication out of the cell, right? Which means that however I am giving taxane to my patient, I may be giving docetaxel or paclitaxel to my patient, but if it is an ABCB1 mutated or overexpressed tumor, very likely that my patient may not respond that well to the treatment as it is documented, right? So it is important that we look at every single minute detail, with utmost urgency, with utmost care. Next important aspect in terms of medication safety is to design and implement safe drug use policies. We use a lot of concentrated electrolytes. There are a lot of drugs which are highly corrosive. Biologicals that we use, today require special attention. So it's important that we keep our eyes and ears open and keep reading, keep understanding what's new happening, and design our drug safety protocol, drug use protocols in accordance with the utmost safety guidelines. Drug recall initializations and validations is something that essentially becomes our responsibility. We discussed about it. Whenever we see any physicochemical changes which are unusual, we see advent of adverse events in our population more than the literature or more than otherwise. Routine use of the drug in our hospital, if you are in a chain of hospital in other hospital of yours, or possibly wherever your friends are working. So it's essential that we do we do recalls, and we understand recalls as well. High risk medication monitoring. So whatever I said about, gave an example of methotrexate, that's essentially what is high risk medication monitoring is, right? So it's important that we look at that aspect. Chemotherapy drug reconstitution, I spoke about it. Patient education and counseling is important today. With the advent of therapy, patients, however, have very easy access to the information. People can read what a drug is, what a drug can do, but a lot of time this information is misinterpreted. A lot of time this interpretation is half understood by people, and we all know, half baked information, half understood information is even dangerous than not knowing something, right? So it's very important that we come forward, being drug expert, teach our patients what all they should expect when they are on treatment, right? To ensure that the patient and the patient caregivers understand when to approach hospital, what are the adverse effects which are part of the therapy, and to ensure that they're not scared out of this. See, many times what happens, when you explain adverse event to a patient, that you may have neutropenia, there might be infections, you may have hair fall, you may have mucositis, stomatitis, A, B, C, D, E, neuropathy, nephropathy. Patient will get scared. People will get scared. So it's important, while we inform or counsel them about how the therapy is given, what are the risks that are associated with this therapy, we teach them what to do in what circumstances, how to bring it down. Say, for example, if the patient is having intolerance to food because of odor, smell, of lack of appetite, we all understand that the nutrition for the patient is important. You have to make an effort to make sure that this patient understand that that having small meals is beneficial for them. You have to make sure that and of course, in this effort, you take help of your clinical nutritionist, who design a proper treatment plan for your patient. And it's very, very important that we do this, do the counseling activity as a multidisciplinary approach. It's very important that a psycho-oncologist is part of the entire effort to ensure that the psychosocial aspect of the disease and the care is taken care, while you are explaining technically about what this drug can do, what can happen. And it should be spelled in a manner that the patient understand it, at the same time doesn't get too scared of it, so that they decide not to take the treatment. It happens on the ground. When you sit and explain treatment to the patient, they refuse to take the treatment, right? So it's important that we become part of the entire counseling team, and ensure that you are available for the patient to answer to give answer to their queries, questions, concerns. Things might be very, very small, appear something which we presume being understood by everybody, but on the ground it doesn't happen, right? So we have to approach our patient families with a intent that I have to tell everything in a manner that they understand it, but they don't get scared out of it. Right? Another important aspect of drug information services, as I said, therapy is changing every single day. Our understanding of cancer is changing with every passing day. We identify new pathways. We identify new ways that a drug, acts a cancer, a cancer cell, adapts to the treatment and become resistant to the treatment. So it's important. People will approach you. They will approach you that I'm giving immunotherapy to a patient. Can I add biological therapy? And if I have to add biological therapy, which biological therapy should I add? Right. So you essentially will become point of contact for people, for your healthcare professionals. Your nurse may ring up and say that the doctor has asked me to give the drug, A. How should I give it? How should I prepare the drug? Should I directly push the diluent? If yes, which diluent? Can I directly push saline? Can I push dextrose? Can I push other available diluents? So it's very, very important that we know all this, right? Because you'll be point of contact for all this. So drug use policy designing, review, and implementation, I think we all understand it. And two very important aspects which essentially are part of care that we give to the patient, right? Essentially are academics and research. uh, being an oncology healthcare professional, it's very, very important that our academic orientation, we do not lose our academic orientation at any point of time. Trust me, guys, we are learner throughout the life, and none of us understand the disease and can call us expert. None of us, be it whoever, because the way this disease presents itself, the way the cancer changes its response, that's something that will surprise you with every now and then. So it's very important that we remain academic. When I say so, as an healthcare professional, it's important that you have an alignment towards doing research projects which will help you in understanding disease process and the drugs better. Incline yourself towards writing papers, write case reports, write case studies, write concept notes, right? If you have understood the disease, if you have understood the therapy, put yourself in writing concept notes. You never know which tomorrow will become a hypothesis, and you or somebody possibly may start working on those, and it can become one of the treatment protocols at some point of time, or a diagnostic protocol at some point of time, right? So is research. If you are an oncology CP and you really want to excel in subject and the profession, it's important that you engage yourself in research. Spend some time, spare some time for research, and ensure that you put your utmost effort in encouraging your own self and your peers, your juniors, your colleagues to do research. Right? That's the only way to excel in areas like oncology. Other things do come up. If you are somebody who's interested, you possibly will go into clinical trials monitoring in hospitals or possibly in clinical trial companies. Ethics committee functioning and documentation review possibly will come to you. Ethics committee monitoring, including review of the clinical trial agreements, because you're the one who understand therapy, you understand what regulations are. You'll be the point of contact in many hospitals about this. The licensing and mandatory documentation, pharmacy licensing, and many other licensing procedures about the drug use. You possibly will be the point of contact. And of course, pharmacy and therapeutics committee conduct and ensuring that it is at a very good health is another very important responsibility, because it is this pharmacy and therapeutics committee where you gather all your clinicians and discuss about drug use and safe drug use and the problems in and around that in the hospital. Clinical audit review and conduct is again important, because especially in oncology, as I said, I mean, the therapy is changing, understanding of therapy is changing, treatment are changing. So clinical audit essentially is to measure our performance I'm sorry, our performance against a specified protocol. It can be international protocol, it can be a national protocol, it can be your own institutional protocol. Now that this protocol most of the time essentially includes drugs, you possibly will be point of contact in conducting those clinical audits. One very important aspect, which I'm sorry I couldn't mention in this particular slide, is being part of multidisciplinary team. Right, today guys, decisions in oncology are not one man decision. It's not just the medical oncologist who sit and decide. It's not just the surgeon who sit and decide. It's not just the radiation oncologist who sit and decide. It's always teamwork, right? Your pathologist, your molecular genomics expert, you yourself or we ourselves, a medical oncologist, a radiation oncologist, a surgical oncologist, an endocrinologist, a gastroenterologist, an infectious disease physician or professional, everybody come together, discuss a patient, and take a decision. It's like this. This is how cancer treatments are practiced today in many institutions. Leave apart small institutions or clinics, but if you go to a larger institution, you will essentially see a multidisciplinary team who is deciding for the patient, not one clinician who is deciding for the patient. So thank you so much, everyone. Thank you so much for your time. Thank you so much for your patience. I'll be more than happy to take questions at any point of time. If you want to connect with me, these are my coordinates. Please feel free. If I am not able to answer immediately over your calls, I'll try to respond back as soon as possible. I'll try to respond on the WhatsApp as well. You can feel free to text me. You can feel free to call me. Feel free to write to me in case if you have any questions. I'll be more than happy to take suggestions if you have any. Thank you so much. Thanks a lot, Dr. Ajit and the entire team, for remembering and inviting me here. I leave the stage open for discussion now.
Thank you so much, sir. Now, if anyone has any questions, they can leave them in the chat box.
Yes, guys. Please come up with your questions. And please fill the feedback form. Everyone, please fill the feedback form. Okay, and come up with the questions. Okay, I think there are questions.
Yes, sir.
Yeah. This is Abhijit. Hey, hi Abhijit. Sorry, I didn't realize you are there. So Abhijit has worked with me in HCG Kolkata. Thanks, man, being there. So your question is, I'm good, man. Thank you. Thanks a lot. Can we develop any strategies by which we can catch any deviations? Catch up any deviation of treatment for any patient regarding their tumor size, grading, and appropriate treatment protocol, because someone prefers NCC and someone ESCO. So what's my opinion? See, my opinion, as I said before, protocols are are our first reference always. You cannot go, you cannot deviate from the protocols to right at the initial stage. right? You have to take a thoughtful decision. Now, whether you to follow ESCO, to follow NCCN, it's up to your institution. ESCO, the ESCO essentially follows or talks about NCCN. The differences between ESMO and ESCO, ESMO and NCCN, but those differences are also not very large. The treatment decisions are taken based on the pharmacokinetic behavior of a drug, the dynamic behavior of a drug, and it essentially does not differ too much. What may be different would be the dose of the drug. What may be different would be monitoring parameters. What possibly different would be the use of pharmacogenomic markers. That's what essentially is the difference. At our level, it's important that we understand the recommendation from all the global bodies and implement something which is implementable to our population and our healthcare ecosystem, right? It's not just one hospital, but it's the entire healthcare ecosystem of the country, right? So whatever capacity we are, it's important that we understand these guidelines, the genesis of these guidelines, how a particular guideline came, what was the reason, what was the protocol, I'm sorry, what was the trial that that established this guideline. And it's important that we understand to that extent, to that level, for us to decide whether I'll follow NCCN or I'll follow ESCO. You may follow NCCN, but you will have certain dosages which you might not be using. So, for example, if NCCN says to use capecitabine at 1,000 milligram or 1,200 milligrams per day, we understand that Indian population doesn't most of people, I'll not say everybody, most of people may have adverse effects beyond 850 milligram per meter square, while the efficacy is same, which is quite well proven. I'm giving an example, not necessarily that we have to practice it this way. You have to take the decision based on your individual patient. This is what we do, right? If you have a patient who is who can tolerate 1000 milligram per meter square, of course you'll give 1000 milligram per meter square to a patient. But decision is always personalized. Decision is always based on your patient's clinical findings, your patient's baseline status of their vital organ functioning, and of course based on that, what kind of monitorings that you can do in your resource, right, at your hospital. If you're in a larger hospital, you have anything and everything. You can do a muga, you can do all advanced scans and diagnostic test, genomics, everything. But if you are in a resource limited setting, if I'm sitting, for example, in Shiv Moga, can I do all this? Answer is I still have no as an answer. I'm still depending upon larger hospitals, farther places for my patient to reach. So you have to think all those things when you implement a protocol. Of course, in oncology, only thing which saves a patient is the right effort at the first time. If you have missed the bus the first time, there is no returning back. If you have compromised the treatment by any means at the first time, there is no returning back. Your patient may say that, okay, I'll take only chemotherapy, I'll not take radiotherapy. Or if I'm taking chemotherapy, I do not want to take biological therapy. You have to make your patient understand that it's not a choice. Oncology is not a choice, right? If something has to be done, it has to be done the hardest way and the best possible way the first time. Because when the disease recurs, understand that we are dealing with something which has evolved over millions of years in the history of this planet. We have evolved like that. Our body, when we say cancer, it's our own body. It knows how to come out of problems, right? And treatment is a problem for cancer cell, right? While we are treating, we are killing a cancer cell, and our body knows ways to come out of it. So when you hit hard the first time. I hope I was able to answer, Abhijit.
Abhijit, and sir, to add on to you, like as you have told about capecitabine example, Abhijit, another thing is some people will not be able to tolerate even 850 mg per meter square. So sometimes physicians choose an alternative like Tegafur as an option, alternate to capecitabine if there is hand-foot syndrome. Some
Yeah.
people, and the dosages, and it is not just the guidelines, the patient tolerability and how they tolerate adverse effects also. The dosages are also altered, and also, the drug changes are made. But it is not like other treatments where you start with some antibiotic, there is some hypersensitivity reaction, and you don't continue that antibiotic. Anti-cancer therapy, you don't have an option. You have to weigh, you have to weigh risks and benefits. You have to treat adverse effects, but you will have to continue the treatment and finish the cycles unless the patient cannot tolerate the adverse effects. So throughout the cycle, your role is very important, but the choice of decision on taking what drugs to use to the patients, it depends on so many things, because the financial status is also very important, the treatment protocols, the clinical trials, and even they see, like when you go to NCCN or something, you see category 1, category 2, category, it's all based on evidence how the treatment options are given in cancer. Just not cancer, in all the diseases, but mainly cancer. You just see the evidence based practice that is implemented in day to day scenarios. And very new drugs are coming up, and many are in clinical trials. If some patients are eligible, it's better to enroll them in clinical trials to get the best possible treatments. So you cannot tell which guidelines you have to follow, but most of the guidelines followed are NCCN, but they are tailored. Those guidelines are taken and tailored according to the settings, because the genomic profile differs from country to country. And some US patients tolerate few drugs, Indian patients tolerate the drugs, different drugs from the same class. So this is how what happens in cancer. And another thing, as clinical pharmacist, the choice of drugs you can choose when alternatives only in case of pre-medication and supportive care medications, where you can play an important role, but not the oncology drugs, where you will not have an option to choose, but you can only choose an alternative in formulations. Like paclitaxel is there. So you have a normal one and you have aqualip formulation to reduce side effects. There you can, you know, include your role to play an important role. If patient is affordable, you can change the formulation to reduce the adverse effects. There you need your drug expertise, but not change the complete paclitaxel and give some other drug. So I think I have added something to this.
Absolutely. I mean, whatever you said is bang on. I mean, that's how that's how routinely that that's the approach that you have to take, right? It's not a single dimensional approach when you are treating somebody for cancer. It's always multidimensional. So you have to think from all the aspects, from your patient, resource, everything put together. So I think there is another question, and thanks, Dr. Publica. I think you have articulated it really nicely. Uh, the question says, as a family student interested in oncology, what are the next steps that I should take, such as internships, free courses, or training programs, etc.? Um, uh, see, Harshada, it depends on, again, the kind of resources you have in hand. If you are, I mean, I don't know from which institution you are. A lot of few institutions, I don't say every institution, but few institutions do have dedicated cancer centers or units within themselves. It's important that you, if you are interested in this specialty, it's important that you spend time over there, right? The only way to, to know the subject is to spend time with your patients, is to spend time reading about the subject. More time you spend, you don't have to look at the clock. That's what I request everybody. I try to practice that myself. Imagine and think about it. If you have a friend who is an oncologist, a trainee, or a friend who is a critical care trainee or emergency medicine trainee, uh, uh, what do you see? You see them being available for your patient every single time. Doesn't matter. I mean, I don't think any of our colleagues, how much ever pressure they are in, at any point of time, they say that, oh God, this is 6 o'clock, I'm leaving. This is 3 o'clock, I'm leaving. I'm starting at 8 in the morning. Should I go by 4 in the evening? I don't think anybody practices like that. Anybody, right? Whoever is dedicated to their patient, and at the same time, I'm not trying to propagate not to have work-life balance. It's very important. It's important that we are at a proper state of mental health to take a right decision for our patients, right? But my request for first 5 years of your career, is to avoid looking at clock, avoid looking at your watch. And if you have a situation in front of you, please go face it. Read about it. When I say situation, a clinical situation, of course, a clinical question in front of you, try to answer it. Try to have more questions. And why is it something happening? Why not is I'm able to find an answer, right? It can be drug, it can be disease, any of those. Coming on to very specific aspects, are there internships? Yes, there are internship programs available in many cancer centers, including HCG, and all our friends whoever are practicing oncology, JSS, HCG, Sri Shankara, I think Esther, Manipal, when I talk about in and around Bangalore and Karnataka, and of course outside as well, Rajiv Gandhi Institute, Delhi, a lot of institutions in every state who offer internship program based on your a place of residence and your training centers or your college. You can choose one. Now, whether it is free or paid, it's completely depending upon the institution. Some institution charge fees, some institution do not. If the kind of trainings that you want to undergo, look at the patient load, and the team that is available over there, more than whether or not you have to pay money. Trust me, 1,000, 2,000, 3,000 rupees, whatever you are paying today per month, right? This is worth when you look back after a year or two. This investment of your time and money is worth, trust me, is really, really worth. If you get it for free, nothing like it. But if you do not and you have the capacity to pay, right? By cutting down some of your expenses, don't party for a day. It's okay, right? Avoid one or two parties. I think that's absolutely fine. But if you invest that money over there, I mean, I'm sure it will give you dividends in future, like nothing that you have ever thought of, right? So yes, there are internship programs, there are courses available, both free and paid. There are training programs, as I said, a lot of our hospitals, I think Dr. Ajit is also hosting a lot of training programs. You can get benefited. A lot of our other friends are also have also organized, do organize in their capacity, their the training programs on various subjects, including oncology. Uh, uh, Again, wherever you are, based on your suitability of time, and of course, please do thorough research before you opt for it, and then take up those programs. But yes, they are available both in India and abroad. Um,
Guys, sir, to add on, I will just tell them. Training
yes,
programs, guys, how you are asking, it will not give you 100% things, but it will teach you the process. Because I myself can tell when I was a student, sir, of yours, just in 1 week span, I have learned how to mix a drug. Even a technician can do it. But the process and the guide will teach you how to do it with knowledge and how to practice it patient. Mixing drugs, a technical person can do, but how much to do, how to do, it's a process. That is what you need a guide, sir, who will teach you how to do it. That's what we have to learn. It's not how
correct.
much we learned, it's that even I don't know anything, even sir is also every day we need to be updated. But we know that we need to refer certain guidelines for certain stuff.
Yep,
So you
agree.
need a guide who will tell you where to refer when you get a problem. Not the documents what your senior says or your trainer says, but your trainer should teach you the process. You can do it by yourself when you learn the process. Actually, to tell, I have learned in HCG how to mix the drugs. I was there for 1 week. I have learned it in 3 days. I was even scared to touch a needle, but I have learned it. But when I don't have an answer, like how sir told why, I didn't go and search any internet or Google. I just read the drug label of every drug. Understood it, how to prepare a drug, what to reconstitute. Then my clarity is that NS or 5D. The label says it correct, so I need not ask someone. I read the adverse effects. I went and told it to patient. I practiced what I have learned. So I learned the process. I did it myself. And I could see that when patient report you back, you will learn it. So any training programs that you will have a good guide to train you and teach the process, you can achieve your goals, but you will have to put efforts in that. It's not where you are learning, but it's how you are learning. It's through personal experience. I'm speaking these words, but it's not very easy to practice in oncology unless you have interest, dedication, because you cannot, like how sir told, forget clock. It's true. We stay till 11 o'clock, 12 o'clock in the hospital when you get a new drug to administer, to watch how patient is reacting to it. Your curiosity, you will learn how to administer drugs. There lies your expertise as a clinical pharmacist. How do you differ from a normal person who works for salary? And this is how you grow and learn. And whatever you learn, if you people start sharing it, this is how people learn. That is like with time and knowledge. That's what it teaches you experience. And I think now sir has learned even, pharmacy, drug distribution, all this stuff which we are not exposed to. Some are in clinicals. So with the time you learn the process, if you learn, you will have so much of knowledge. So never think you are restricted only with the biosafety cabinets in oncology department. There are many, many things to explore: bone marrow transplants, hematology, CAR T cell therapies. A clinical pharmacist can be part of anything in oncology when you have patience and you have that attitude of learning. You people will do it. And actually, to tell, there are so many, things in online that you can learn, but you need a person who will guide you where to start and how to learn. That is what is important, but everything is available on Google. A guide is just to guide you how to go through that process. In a setting like India, you will have to practice, and there are a lot many opportunities coming up because healthcare setting needs so many hands to work in oncology. Just physicians cannot lead this space. Sir, I think
Agree.
the time
Agree,
when
Dr.
we
Prabhakar.
agreed, we don't even have an outline where to go, how to go about. It's
Yeah.
what time taught us. I think.
So,
There is a
agree.
question, very interesting question by Ajay Krishnan. Dr.
Yeah,
Priya, you can take
absolutely.
this up. Yeah.
I was reading that. So it says that about certain fellowships that are available, some are abroad institutes. Are they worth doing it online? So if you're looking at starting state of your of your career and trainings, I would strongly suggest to do hands-on.
Yes, in
Um,
the
yeah,
hospitals.
in the hospitals. If you can go abroad and do it, nothing like it, right? But I think today, uh, our own self, our friends, those who are dedicating their time in training or giving fellowships, uh, has enough knowledge, patient pool, and technology available in India that you can learn the subject, basics of the subject, and to a certain extent in certain institutes, really advanced practices being here in India itself. When you're spending time, I would suggest spend time in taking a step further from there. If you've completed your PharmD, you want to learn oncology, fellowships in India are pretty good now. Yeah? Whether GSS gives it, Sri Shankara offers it, we are also doing it. I mean, I really take pride in being the first to introduce it in India, all thanks to the wonderful team that I have, the guidance that I had from our own chairman, chairman of HCG Group, Dr. B.S. Ajay Kumar, who himself is quite inclined towards good clinical pharmacy practices and having good professionals around, and that created a good ripple around, and we have very good institutions today, right? Everybody, trust me, everybody who is offering the fellowship have very good facilities, good patient footfall, uh, which helps in getting yourself trained on practical aspects of care, which is important. Coming on to whether to take help from online sources, it's good, but that might not help you completely in understanding the clinical nuances. You may be able to know what happens when, but trust me, it's very different when it happens. You may learn that when somebody has hypokalemia, give potassium. But when you start giving potassium, that's when it makes difference, right? So it's
True.
while it's important to learn when to give potassium, it's equally important to stand there and give potassium to somebody, right? So choose a course where you have hands-on. India or abroad, your choice. Options in both the parts of the world are equally good. There's nothing less and nothing more. If you want to really specialize, you can think of doing it further at any point of time.
Absolutely. And I want to add to this, guys. Then, when you want to learn theory, there are certain courses, even we provide 3 months, 6 months courses, 4 months courses, some weeks courses, where you want to just learn the theory. Okay. We get the experts, you learn the theory. But when it comes to specific, destinations like fellowships or residency, you must need the practicals. You must need the hands-on training. Okay. So in that involve anywhere, wherever you get the hospitals, you get the patient pool, you get the right person to teach, and you get the full-fledged practicals. Okay.
I totally agree. Totally agree with you, Rajit. I mean, you yourself have done your PhD in cardiology. I mean, I'm
Cardiology.
sure
Yeah,
there's nobody, and here in this forum is better who can give the essence of what's the difference. Difference in just reading and difference in being
absolutely.
part of the entire process.
Absolutely, absolutely. See, I mean, that's very important when you are in the wards, when you are looking into the patient file, when you are looking at the patient, when you understand the whole process, then only you get to know, like, okay, how typical, how tough, and how realistic it is. You
Yeah.
know,
Yeah. It's not
theory,
just about reading a book and interpret. It's
yes,
definitely not that.
absolutely.
So
Yes,
please engage yourself in more hands-on, more practical things.
absolutely.
It's always good to read theory. Please read.
Yeah,
I'm sure either Dr. Ajit or myself or Dr. Publica, whatever she said,
yes,
we are not discouraging you from taking up theory courses.
absolutely
It is
not. Yes,
extremely important. But if you are somebody looking forward to practice the profession, to grow more into the profession, it's important that you put yourself into it while you
yeah,
read about.
absolutely.
So I think there's one more question from Ishwar, which says most Indian
Guys, one
hospitals.
more last question after this because it's past
9:30.
9:30. Okay. One more question. And I just saw the feedback form. You guys are keeping a lot of questions in the feedback form, but you're not asking here. That's another problem. Okay. You have to ask the real time, questions and discuss with the fellows here and
I
discuss with the, speakers here, right? And you can speak also. Now you have access to speak also. Okay.
Should we?
Dr. Ajit, to tell if you guys, even after this, if you have doubts, please post all your questions in the group, and or even you can keep posting in the chat box even tomorrow and throughout the week, and I will be answering through the chat so that.
No, definitely. And we are getting a lot of interesting questions in the feedback forms
And don't
that I'll be
worry,
sharing with the people. Yeah, I'll
with
be
all your
sharing with our resource
questions,
persons.
at the
Yes.
end of the 5 days, we'll have a good panel discussion. Even if all your questions will be answered, at least in a poster in a LinkedIn, at least there you can check it out with all your questions answered by the end of this conclave. None
Yeah.
of your questions will be unanswered. Like how, and another thing to add on, you people were asking how online internships will help and courses will help. See, online courses with an example, I'll tell you, it will help you to tell you. You can use a Mostellel formula to calculate a dosage for a patient. But on hands training in the hospital will tell you whether that dose is fit for the patient or not. If you have to do a dosage modification based on liver function status or organ function status of a patient. Patient counseling points on web will tell you what to counsel a patient. But in the ward, when you do, what to filter from that content will help you. That's how you learn. Online training will give you knowledge. Practical training in hospital will help you to practice with the patient, because the same set of instructions varies for every patient with the same regimen. So this is how it will make a difference. Means with small example. And for your questions to be answered, please send all the questions to Dr. Ajit, and Dr. Ajit, please send all the questions so that none of them will be left unanswered. from all the speakers.
Okay, I think there are two questions. I'll quickly touch upon that. One is about most hospitals. This from Ishwar says that most hospitals still lack dedicated oncology pharmacists. What immediate changes do we believe are feasible for us to grow in this? Uh, it lies in our hand. I mean, this is what I always say. It is not the regulator. It is not the government. It is not anybody else, but it is us. If I, as a as a healthcare professional, practice my profession, with utmost dedication, uh, and I'm true to what I'm doing when I say so. If my interventions are evidence based, if my interventions are making positive change in the practice, uh, you do not have to wait for anything else. The kind of changes that we are seeing today in Indian healthcare ecosystem, where a lot of our colleagues are doing wonderful work as a CP, especially and also in oncology as well. It's purely based on the kind of work they have done, the kind of change they were able to make in patients' life or in their in their hospital practice. So people do recognize that, right? So the only thing I believe, I try to practice, I try to request my colleague, my peers, and wherever I'm speaking or talking to people, is to let's start from our own self. Let us sit and introspect what I did today, whether it is right, wrong, how much was my effort? Was my effort 100%? If my effort was 100%, I'm sure I'll make the difference. And one last thing about it is, when you are part of an hospital ecosystem, make sure that your presence is felt. You're not part of healthcare ecosystem, a hospital ecosystem, just to do some audits, but your clinical skills, your drug knowledge should make positive difference, and that's what will change and is changing the entire ecosystem. I think one last question that was, and it's about sorry, I lost it somewhere. Yeah. Um, Interested in experimental oncology. So if you are interested, somebody who's interested in translational research and translational oncology, we call it translational research in oncology. Yes, there are a lot of biotech labs who do accept PharmD graduates as part of the training. Point is how interested you are, how interesting is your proposal. So if it is such, you are very widely accepted. A lot of my own students and my own colleagues who have worked in our labs, our pathology lab, I'm talking about histopathology tissue lab, in my genomics lab, have learned the art, and now are practicing abroad, and and have gained further experiences, and are working in good reputed institutions. So definitely you can do it. And I think the next question is answered by Dr. Prablika. Uh, so I think with this we with this we come to an end. Saida says, are there any books? Which I think Prablika has answered.
So, guys,
Thank
we'll end this here. Fatima, over to you.
Yes, sir. Thank you so much, Dr. Priyank, for those insightful perspectives. Your session wonderfully highlighted how clinical pharmacists elevate the quality, safety, and coordination in oncology care. As we wrap up day one of the Oncology Pharmacy Conclave 2025, I extend heartfelt thanks to our esteemed speakers, Dr. Priyank Tripathi and Dr. Pravalika Votukuru, for sharing their knowledge and expertise with us. A big thank you to all the participants for your engagement, enthusiasm, and commitment to learning. Today has set a strong foundation for the days ahead. Tomorrow, on the 9th of December, we look forward to having you all back at 7 p.m. sharp. Until then, stay inspired, stay curious, and keep advancing the science and soul of oncology practice. Good night, and thank you all for being with us today. Thank you, sir.
Thank you, Fatima. Thank you, Dr. Priyank. Thank you, Dr. Pravalika. Thank you, everyone, for joining. See you tomorrow at 7. Bye bye. Take care, guys. Good night.
you. Thank you. Good night.